All right. Now, the folks who are left in the room are the really dedicated people, so this is going to be an interesting, lively, and fun discussion. And I'm happy to report that in this session, we'll also be having an activity, so we'll get you all moving before too long. So just to start off, I think in the morning, Joe, in his framing remarks, talked about the need to get the unit of analysis right. So to move from talking about schemes to talking about the system. And then in the course of the morning, okay.
It's over here. Keep going.
In the course of the morning, we heard multiple speakers talk about the problem of fragmentation. Fragmentation in the sector, across levels, across programs, and that indeed is going to be the theme for today, or rather for this session. And so we're going to hear about 3 different types of fragmentation and 3 different attempts to bring greater integration. So we'll start with Susan, whom you've all now come to know and love. She's going to be presenting some really interesting and exciting work she's been doing for several years now, looking at cross-programmatic efficiencies, inefficiencies, and how to get to efficiencies. And then we're going to hear from Dr. Parfait, who's the head of the Department for Planning, Monitoring and Evaluation, and Health Financing at the Ministry of Health in Rwanda. And many of you in this room probably know about how successful Rwanda has been at getting different forms of integration across, especially across donor programs. And so we're looking forward to hearing Dr. Parfait from you about that. Then we're going to shift gears a little bit and talk about the need for integrating health and health funds with other sectors. And so Scott Greer from the University of Michigan, you spoke so much about all the ministers in the room that I assumed you were one of them. He's going to be telling us about some really interesting work he and his colleagues are doing on this question of a multi-sectoral response, which, as we all know, especially given our experience with COVID, how important that is to bring money from health together with money from other sectors. And so we're going to be, and that's when we'll also get a chance to move around and we'll be having an activity. And then, of course, last but not least, we'll be hearing from my good friend Wangari Nganga, who's the health advisor in the Presidential Policy and Strategy Unit, the Office of the President in Kenya. And so she sits right at the top over there. And what it means to be integrating policy and programs across different levels of government. And that theme, I think, has come up in several presentations. We heard about it in Uganda. We heard about it in Tanzania. So we'll get to hear a perspective from Kenya, where devolution started a decade ago, and it's been an interesting journey. So without much further ado, I'll call Susan up. And Susan, you have 7 minutes, and I'm going to be monitoring you.
So I'm kind of I consider myself the warm-up act to what Dr. Parfait will be presenting as a concrete example in Rwanda. And so we've been supporting this work for a number of years now as WHO on this issue and question around health programs and health systems and integration and really how to break down some of these barriers into much more productive evidence-based dialogue and to really plot a way forward of what does a health systems agenda mean for health programs, often times that are often donor supported in nature. And so what we do as background to this work is we use, it's really quite straightforward. We use applied health systems analysis. So instead of saying what's different about health programs, and so those are specific objectives or interventions, so HIV, TB, immunization, NCDs, we say, okay, let's take a step back and look at what's common. And those are the input functions, so the information systems, the supply chains, the procurement systems. but also the financing systems, the purchasing, the governance, the planning, the actual facilities and service delivery. And if we analyze the individual health programs based upon these common core health functions, and then look across, not just from a policy standpoint, but actually go down into the facility level, go down to the district level, and understand how those programmatic funding flows actually play out in terms of the organization of services. Because oftentimes we see a really strong disconnect between what you think of the national policies related to integrated primary care, at the point of delivery, and what we actually see in practice in terms of fragmentation in health workers, supply chains, the person going into multiple doors for multiple services, all the common stories that we know. And what this work does is build a process of consensus across the system level planners, but also the program leaders, to say, okay, where are the egregious areas of duplication and real misalignment in the system. And let's have that as the agreed upon system agenda. So instead of talking about health systems as this black box, let's say, well, no, what we really mean here is these are specific areas, supply chain, for instance, in Ghana. Instead of having a separate supply chain for donor-supported medicines and then the essential medicines from the government funds, how do we support a process? How does the government support a process of alignment and integration along those lines? And so really trying to create a much more productive area for this type of engagement. And so I'm not going to give a presentation around the areas of fragmentation because we know them. We know, and they are quite extreme. I mean, the 27 reporting information systems, meaning pieces of paper that go to different people in different ways, the really circular funding flows, the off-budget, off-cycle. I think I wouldn't underestimate it would not be hyperbolic, the degree of what we imagine of that fragmentation, but also just how much that does really impact on the service delivery side. A good example for me always comes to in South Africa, where there was a policy of that HIV and TB services should be integrated in a primary care level. And then when you go and you speak to the facility managers, they say, well, how could that be possible? We get our funds through a separate conditional grant. We're only allowed to hire staff, and we're only allowed to procure goods in a certain way for these specific areas that's separate from the rest of the primary care system. And then you talk to the district managers, and they've actually even hired 4 auditors to go and make sure that the people who have been hired under each of these different funding flows are only serving the different programmatic areas and not, for instance, in the overall operating theater. And so these types of examples that are important to have this evidence base of really tying through what is the fragmentation, but also what is the actual impact at the service delivery level. And so what we found is in this process is that the actual building of consensus and identifying these priority 3 to 5 areas for integration or coordination is the easy part. What actually then becomes quite difficult is the issue of the politics of rearranging those funding flows. What does it mean for health workers who are paid in one way to be part of another way? I mean, this happened in the polio program in India, whereby the government said, okay, we'll take up the funding for this program as the EPI program or the polio program was transitioning out. There was a number of health workers or surveillance workers that weren't just surveilling for polio, but were surveilling for other conditions. And then the key constraint became, well, then what happens when you have a set of workers that are paid on a separate salary scale, separate processes that now need to become part of the civil service? And so this really touches and being very clear-eyed about those politics up front. And then another topic that's come up a lot in the morning session is this issue of decentralization. And I bring up these last 2 issues because I don't think that they're discussed enough in terms of what we're seeing as we heard, and Gemini and I have had a lot of discussions about this in Tanzania, in the context of the DFF move. you have a certain amount of funds moving through that mechanism in favor of facility autonomy and better financial management closer to where the services are delivered. But the programmatic funds, and in this case often donor supported, they remain centralized. And this happened in Nigeria, this has happened in Ghana, this has happened in many countries where we do this analysis, and that not only creates fragmentation in the system, but also can create difficulties in leading to the last point around accountability mechanisms, because those funds get sent down in a very heavily earmarked in-kind way where there's very little discretionary authority at lower levels of the system, whereas those lower levels of the system are ultimately accountable for reporting on those programmatic outcomes. And if there's been a recognition and an adoption of policies around integrated service delivery, about bringing together inputs in a more efficient manner, and yet the people at the lower levels of the system don't have that discretionary authority. I mean, we heard in Uganda 41% of total health expenditure coming through donor channels. It's quite remarkable when you think about the magnitude of those funding flows. And so as we see these policies of integrated service delivery, we have this mismatch and misalignment between accountability and discretionary authority, but we also have a mismatch in terms of what we're seeing at a more global level in terms of, at least in the context of Gavi and the Global Fund, in terms of wanting more rigorous co-financing, more detailed matching of resource tracking and KPIs that are dollar for dollar, these specific indicators. What does that mean in a context of trying to move towards more integrated, coordinated systems, particularly at frontline primary care? And this misalignment and how we talk more about this importance of alignment and who are these accountability mechanisms really running towards? Are they running towards the pregnant mother with HIV who's at risk for TB and whose children are at risk for malaria, or are they running up to the donors of the donors of the donors? And I think these are discussions that we need to put on the table to bring back to the politics question at the end. And so with this, I want to say that despite these challenges, we did have a really productive workshop in June where we heard a lot of examples of country-led, ministry-led, citizen-led processes. And also just as a precursor, there'll be a transition session tonight where some of these examples will be brought up as well, whereby we see more coherent, efficient, joined up and coordinated approaches coming together. And I'll put up, we have a website where we have examples, but Dr. Parfait has a concrete example from Rwanda. So over to you, Dr. Parfait. Thanks.
Thank you very much, Susan, for the introduction. I just prepared few slides just to give you not the background, because Susan already well mentioned it. I'll just give you, share with you what we have in Rwanda in terms of how can we reduce programmatic inefficiencies. So let's start by the definition, the normal definition of efficiency: use less, but achieve more. That's what they used to say. But some school of thought, they say use minimum but achieve more. So I think both of them are quite right. So I will just give you an example of Rwanda. I'll just focusing about the coordination. Of course, goes with the alignment, resources, donor coordination, but targeting the citizen that we are all serving on a daily basis. So I'll spend time on this slide. These are a kind of there's been a lot of declarations, treaties. We start with Paris, Rome, Addis, Busan, all about how can we use efficiently to achieve more in our countries. So in terms of materializing this kind of declaration, the government of Rwanda has initiated a lot of processes and reform. Even up to now, we're still implementing a reform. Why? It's because of the political leadership. That's one of my colleagues will mention it. Also the political will that is there. So we start with, we had the aid policy 2006, MOU between the government of Rwanda, represented by the Ministry of Finance, with all partners. We agree about the aid modality, general budget support, sector budget support, project model, off budget, on budget, technical assistance, pool funding, all those modalities. We agreed on that. And from there, we also agree how we're going to monitor for accountability purposes that Susan has mentioned. So we tried again to make sure that how can also see people bring more value, especially donors. That's why we came up with the division of labor policies with different donor specific sectors so that they don't have duplication, as one of the colleagues has mentioned in the morning. So at the sector level, this has been materialized in terms of using guideline and how processes, how their donor being coordinated, especially when they go to engage. There have been a lot of training, policy dialogue, how you approach the donors. You know, sometimes the donor comes, they end up not understand the priority of the government, because government is so many things. We start with someone, we want infrastructure, ambulance, referral hospital, and you get confused. So we had some time of capacity building, training officials, and implement this sector-wide approach guideline up to the level of district. Even mayors and also people are working in the mayor to engage when the partner comes, when we are going to allocate partners, as one of the colleagues also mentioned in the morning. So from there, we also initiate how can we capture the data. Some of the colleagues in the morning mentioned about the cartography, the resource mapping. So how partners are, what are they use, what kind of projects model they are using, money, what are the impacts, are they money used from the lower level, or are they used by the central level? So then we institutionalize the national resource tracking mechanism, where all partner stakeholders, including the private sector, should report the government. And we use the stick on the other side. If you don't report, we stop the MOU, the Memorandum of Understanding. That means operation means you have to report. So it was not easy if now we still engage. It's not like it's a reinforcing mechanism, but more participatory. And there's been, in terms of government now, reform, how we need to operate. Susan mentioned about the TB, malaria. We used to have separate national TB program, malaria program, HIV program. We put them under one umbrella, and it became small department, one institution. That was in 2011. The government was instructed all the reforms to ensure that can we separate policy from the implementation. You find that the Ministry of Health, they're also implementing. They are constructing, they are planning, they are doing immunization. So we try to separate the function, policy and implementation. But that was 2011. At that time, I can tell you there was a lot of resistance. People don't even understand. Some of the ministry kept some of the small department units, like maternal and child health. You release all the things, but you still also the MNSH. But then it has gone, HIV has gone. So for the case of the ministry, I can tell you, at that time, 2011, maternal and child health remained at the Ministry of Health. So the government again did another assessment, go again, look at all the policy entities, reform again. And then we sent the Department of Maternal and Child Health. We remain free as a policy entity with 4 functions. Number 1, policy making. Number 2, monitoring the implementation of the policy. Number 3, overall capacity building. Number 4 is resource mobilization. We are not doing any implementation. All the implementation goes down with specific agency that the government has instituted. And within those institutions, we create what we call a single project implementation unit, department in charge of coordinating all the own budget projects that we have. I give you an example like Gavi, Gates, CDC, Pefamani. So all of are going to the government. So this is quite of the way things have. You see, the ministry remain with different with function, but we create different institutions. One in human resource facilities, one in charge of the supply, another one food and regulation, another one all the programs. Just 2 minutes, I'll be done. So for the medical supply, since it's the procurement is an issue that we need a lot of process. You know, there are also bureaucracy in the procurement. Government institute again another reform to 2020 to make it more semi-autonomous. And it's become a state-owned company, but more autonomous so you can procure the supplies. So what I just want to end up my this presentation. I just share with you what are the lesson learned from this the lesson process. Number one, we see that political will can drive everything. If the political consistently provided, it can change everything. So we have seen it in our case. This is just in this the court of one of the court of our president. So it has to be provided at every stage. So to ensure that the implementer or the policy entities that have been instructed to start the reform, so that it can bring more change. Number two, we have learned that we can work together to achieve more. That intersectoral collaboration. I didn't mention it, but one of my colleagues, they'll mention after. Lastly, it's being more open and intentional to embrace reform. We have seen throughout the process. I can tell you, we have started a lot of stick, but now we embrace any reform we are bringing. We are very passionate about the reform because we have seen that what a reform has been brought to us. So let's be, we talk to ourselves that let's continue to be more open and intention to bring the reform as far as it's bring more result and also change the life of our people. So I'll end my remarks are showing that even though things are there, challenges are there, let's start small, but we can achieve more fast. Thank you very much.
Thank you so much. So I'm going to stop here and take a couple of questions for these two great presentations. The importance of integration and the practical example of how Rwanda achieved it. Any questions, any clarification questions, any comments? Do introduce yourself before you ask.
Thank you. Shehla Zaidi from Aga Khan University, Pakistan. So I had a question for our colleague from Rwanda on the SWAPS implementation experience. SWAPS have been there for several years, some decades now. In many countries, they've been attempted, but haven't worked well. So I was interested in asking that what aspect of SWAP implementation really clicked to move the system in Rwanda. You did mention resource tracking and expenditure tracking. So particularly, did that help? Was that a lever to move towards better coordination and efficiency? If so, were there challenges faced in terms of transparency of data? How often was it done? Was there capacity to engage with the data? So it would be great to have some more deeper insights on this particular aspect.
Thanks. Yeah, thanks, Dr. Perfect. I found your presentation oh, sorry.
Everybody should know who you are.
Okay, my name is Felix. I'm from Nigeria. You know from my voice, you know I'm Nigerian. And I represent Africa in the Health System Global Board. So, Dr. Perfect, thanks a lot. And we hear a lot about Rwanda. So I'm actually interested in how you were able to get the donors to report. So in terms of accountability, because we struggle with that in most countries. So for instance, we do NHA, the National Health Accounts, and they do not support that process. I mean, WHO colleagues are here. But getting the data from donors and from the implementing partners is a major challenge. So I was wondering if there are things we can learn from Rwanda, maybe some sticks and some carrots. Thank you.
Thank you. My name is Pratap. I'm from Strathmore Business School in Nairobi, Kenya. My question to Rwanda is really, it's great how you engage with the development partners, but I would really like to understand how this engagement works with the private sector and innovation and innovative approaches through the private sector, maybe taking a specific case of Babylon Health and how they might engage and how smaller, less funded partners might be able to engage with the government.
Yeah, thank you very much. For the SWAP implementation, as I mentioned, it's a long journey. I can't tell you that we have reached where we want to reach. As I will speak to now, we also reassess the alignment processes, especially also the SWAP mechanism. I'll just focus on on one aspect on the SWAP. Ownership, coordination, I will say that they're quite doing well. But the other thing that we still continue to reassess is the accountability of management of results. So especially when you partner with someone, sometimes that's what the discussion we keep engaging with them. You say, how do you expect me if you say that I'm a partner, X, and you have given one district and say, okay, I'll build two or three health center, and yet you want to manage you want to account the result, reduction of maternal mortality. Those are the outcome. You say, you government, you put the bar so high. So let's see how we can engage about the indicators, the result. So that's what we are. I will say that now we are doing the alignment diagnostic exercise with three main work stream. We are doing the planning, the monitoring, the evaluation, how we account the result, but also the reporting. So the assessment is ongoing. We engage each and every partner. Probably one what we'll get from there will draw some action plan and see how we can improve, especially in that aspect of management of results. So how donor report on it? I won't see the normal way of carrot and stick. In French, they say, let me use another stick. In French, they say, deux poids, deux mesures. So, from the discussion on the donor, I say, you guys, you told us to report. Okay, we'll report. Do you give us a feedback? Give feedback what I've reported. If I report, did you engage me through the policy dialogue where if I continue to be aligned? So that's why what the government, I ensure them that let's have continuous policy dialogue so that even though we say that it's stick and carrot, of course, if you don't report, we'll knock on, at your door, but you feel that obligation because you are part of the processes, all these policy dialogue forum, you get engaged, we prepare together, the matrix of sector performance, all those things, we go together. So as we speak now, this journey has started 11 years ago. But now, I can tell you, reporting to us is very easy. You just send an email and report immediately because they understand. Because if I report, the government will call me even to analyze the data together. We'll do the analysis and the reports, and we'll share the result that come from the HRT. And they'll produce the HRTT report on a yearly basis. So it's no longer the stick and carrot, even though it's still there. So how do we engage private sector? Private sector is, I would say that in Rwanda, the private sector is not too strong compared to the public. It's still, we are trying to make sure that there is a low, the high engagement from the private sector. There is two ways we engaged the private sector. Number one of the issues that we met with, we met when we discussed the private sector, they don't have time to go for policy dialogue. They're just business. let's see what are the opportunities. When do you have a loan, or those are the things that you want. They don't want to sit and understand what are the policy context, what is in the sector, what are the opportunities. You just want, come, bring, show me the, exhibition, all this event. That's what they want. So what we did, we keep engaging them, this policy dialogue forum, also build their capacity as a government so they can understand the priority. Sometimes they don't even know how to interpret the priority of the government. So we have been engaging them, and we also support them when they reach a way of investment. There is some of the incentive the government help them to achieve. Like I give an example, Babel. Yeah, Babel is a digital company, but the government has helped them to access, to have the community health insurance, so that people who are not able, who want to get those digital health services, they can get that. But I can tell you it was not an easy conversation. They tell us the tariff is very low, as we have to call them as a government, because we are the one who are suffering, because the people want the services. We brought them in our room. We showed them the mathematics, volume of project. This somewhere business. But if normal investors say, no, I don't want those tariff. They are very low. But when they see the data about the number of consultation, outpatient visit, all those things, open online, digital visits, they get some sense, and we keep engaging them to do that. So it's still a work in progress with others. Some others come with very aggressivity. They are so aggressive. You don't give them that incentive, I will go. Okay, you go if you don't want, because we want to prioritize people. It's a people. We use a people-centered approach. Even though you want to bring MRI, it's okay. Bring MRI, but if the people are not able to access, it doesn't mean, So we have so many partners that has come with high technology, and we help them to ensure that our people, with the low tariff of community-based insurance, they can get those services. Of course, they can treat private people, but also because of the insurance coverage quite high. Thank you.
Thank you so much. I know there were a few other hands up, so maybe during the coffee break, or perhaps at the end of the session, I'm being very optimistic, we'll still have more time for questions. So Scott, if you want to come up for the next part of this discussion.
So, we spent all morning admiring the quality of the conversation in the room, and we're very aware that we are academic researchers. So a lot of what we're going to be trying to do is to take some basic findings that we are developing in a research review project and try to get your thinking, to try and get some of your ideas, and to stimulate what we hope is a good conversation. So it would be madness to listen to me for 40 minutes. But what I offer is that you're going to substantially be able to listen to each other, and we hope we can improve the conversation. So that's us. Marie is our online person who will make an appearance from cyberspace at the end to bring in the insights of the people around the world. And this is what bothers us, and this is what the WHO team commissioned us to think about. It's the classic problem of working together. Doing something intersectorally, or often even within the health sector or any other sector, can require lots of different budgets. The primary care budget and the hospital budget, the education budget and the primary care budget. You know the problem. This donor's budget and that donor's budget, that disease budget and the other disease budget. Now, oddly enough, there's a lot of literature on what allows intersectoral governance and intersectoral programming to work. This is an enormous number of gray and publications and scholarly publications and evaluations. But there's strangely little on the practical problem of how you write a budget that's going to do the job, how you design your budgeting procedures in order to make sure that your intersectoral plan is going to work. At least how to get rid of the barriers to getting your plan to work. So the question that we asked of the literature, of the accumulated wisdom of the researchers of the world, is what budgeting techniques contribute to effective intersectoral action for health, and why? This is because we're academics, we have to show you that we did a lot of work starting with 1,700 articles, and we looked across both generic budgeting conversations and also specific sectors, like nutrition and water and sanitation are both areas where you have to work together. There's no one sector answer to any of the problems. And then we coded it about questions like, did they pool budgets at a given level? How was coordination organized? This was a lot of work, and what we came up with is what Pranitha is going to present in just a moment.
Thanks, Dr. Greer. So as Dr. Greer mentioned, we're in the middle of this project right now. So this is the current results that we are finding. And what we find is that there are three important dimensions to cross-sectoral programming. First is coordination, the second is joint budget allocations, and the third is monitoring. And what we find is the most successful cross-sectoral programmings happen when there's elements of all three, and when there's elements of two, it's moderately successful. But of these, joint budget allocation is a key factor. And then beyond the different dimensions of cross-sectoral, like coordination, joint allocation, and monitoring, there's also levels of where the cross-sectoral coordination programming is happening. Is it at the central level, the department level, or at the implementation or program level? And what we find is that mainly coordination is happening at the central level, and we find that this is usually the case until there is knowledge, capacity, and buy-in at the department level. Additionally, there are a large set of context factors and facilitators that must be present to facilitate the three dimensions and also the three levels. So I will quickly put this up, but a lot of these have been mentioned throughout the presentations today. We discussed program-based budgeting. We talked about political will. That's coming up as like an important theme throughout our conversations. Capacity building, results-based approaches, using medium-term expenditure frameworks as opposed to short-term, we find increases facilitates coordination between sectors, and also improved knowledge and shared knowledge across sectors. So I'm going to quickly go through a case study to kind of show this in practice. So this example comes from Nepal. So Nepal implemented a multi-sectoral action for nutrition from 2013 to 2017. And basically, the program had two key dimensions. The first was coordinating and training on the importance of nutrition across the different ministries. So they would hold these like central conferences where people, representatives from each of these departments would come and understand how their sector contributes to nutrition within Nepal. So that was the first dimension. And the second dimension was that at the central level, the Ministry of Finance allocated budgets to each of these ministries specifically for nutrition. And these were supposed to be based on the learnings that happened at the conferences that were held. And what they found in a review of this program is that it was really useful and successful in increasing understanding across sectors, which is one of the facilitators that we discussed, and sharpening the focus of where there should be focus and when they should be focused on nutrition, and then improving awareness about the urgent need for working across sectors. But we are not sure what the policy impact was at the implementation level. We know that there's coordination at the central and the department levels post this, but what does this mean for coordination in implementation? So with that, I will hand back to Dr. Greer to introduce the activity.
Thank you, Pranitha. So that was an example of, in this case, how you had a fairly centralized system that was designed at the same time to build the learning and the engagement and the input from other areas that would allow it to become a more entrenched intersectoral operation. Now, what we'd like to do in this is move into an exercise by table. If you'd prefer to work in French when we start the exercise, you might want to sort of concentrate at one of the tables with fewer people, because we don't want language to be a problem. And what we're going to talk about is the thing that is sitting on the table. It's this, where we left some hard copies. And all we did was we posted a number of different programs, but there's two axes. One is, how do you coordinate? Do you coordinate at the center of the government, in the president's office or the prime minister? Do you coordinate with departments? And do you focus on implementation or do you not coordinate, which is possibly the norm? And equally, do you centralize joint budget allocation? Is it done by departments, or is it at the level of the implementers? Now, this is merely something to be thinking with. This is a tool for thinking as a way to come up with a concrete program and think about what went right, what went wrong, what you learned, who you trust at the end of it. And the point is to start answering these questions. So what I'd like you to do is take 10 minutes, and if you want to write on the hard copies, that's fine. And then we'll have a larger discussion of what kinds of conclusions you came to, what kinds of thoughts you had about how to get intersectoral budgeting and coordination to actually work in practice and build the capacity to work for the future. So these are the questions. I'd like to call attention to the bottom one of what kinds of research questions would you like answered.
The questions are also at the back of the sheet. And if some tables want to get together, you're allowed to do that as well. If you want to join this table, for example.
So talk for 10 minutes, and then we'll come back around to discuss what we learned. Okay. We've been hearing a lot of really good conversations. And now we were wondering if we'd be able to get a first enterprising table to report the conversations are so good that they're still going. But I'm hoping that we can bring the conversations together and sort of share some of the most exciting things that came out of your conversations on one of these topics, about a particularly interesting program that illuminates one of these problems. Do we have in particular, hi Felix.
There you go.
Wow, okay. Yeah, thanks, everyone. It was interesting having this conversation. So she's from Pakistan, I'm from Nigeria, and we shared similar, had like in terms of context, where you have a central government, and we recognize the importance of having a central planning for budget. So for instance, for nutrition, in Nigeria, for instance, we have a multi-sectoral plan for nutrition. You have all the sectors, agri, women affairs, health, who kind of contribute to that plan. And then, so the budgeting and allocation is kind of coordinated by the Ministry of Finance, Budget and National Planning. And the secretariat for this multi-sectoral plan is domiciled within that ministry. So it makes it a lot easier to make a case for nutrition, unlike before when nutrition, you just had pockets of it within the Ministry of Budget. And I mean, in Ministry of Health, for instance, you just have, let's say, a nutrition division within public health department. And nutrition was not really given prominence because you had HIV, TB, malaria, who were getting all the big funding. And so we recognized that it was important that if you have that central coordination for allocating resources, then it makes it a lot easier. Then we also recognize for that too, we recognize that the different sectors or departments implement when they come together to develop the budget, and it is not just one department coordinating, it makes it a lot easier for that engagement. But another thing we also flagged was the importance of capacity. So if there is low capacity within maybe the departments and all, they may not be able to identify which programs are to be given priority and all. I'm sorry, I didn't really write all this down, but maybe one of my colleagues can add to what we discussed. Okay, they said I did well.
And we have a volunteer over here, I believe.
Thanks, Scott. This exercise is I felt like Harry Potter seeking the philosophical stone, because this exercise is very complex to develop. But with my fellow colleagues, we start to debate about how to break this traditional centralized budgeting in every policy sector in different countries. And then we move it to the implement sector, to how to this central budgeting can change while people that are implementing different policy initiatives realize that they have different outcomes, different budgets, but they are part of the same government. They are part of the same outcomes for being successful. So we realize that the power of the people that are implementing is the key issue for improved coordination. A coordination that will be part of each government that are trying to move forward in how they plan their policy development. But the problem is that the people that realize the necessity of coordinate budgets, but also outcomes, is the people that not in many cases made the decisions about how to allocate budgeting with a unique approach. We need budgeting and coordination, but with shared outcomes. If we try to coordinate multi-sectoral actions with different budgets and without shared outcomes, the problem is that we have an interest research question. How to move, what are the barriers and the facilitators to coordinate multi-sectoral budgeting with shared outcomes? And I think what is the main problem that different countries are facing right now, even if they are federal countries or centralized governments, they are facing the same question. They are working for the same government with different budgets and with different outcomes. They don't have any kind of incentive to collaborate to move forward with different policy development. I'm sorry, my name Claudio Mendes, Universidad Austral de Chile. Thanks.
Yeah. So that was fairly downbeat. Did anybody have a happy story about the power of budgeting to make the world a better place?
Oh. Thank you very much. I just wanted to share about the budgeting. I think everything should start with the planning rather than budgeting. Yeah, the reason why I mention it, let me share with you the experience that we have. I mentioned it here, one of the reform we had in 2014. When we used to plan, when you used to somehow to plan, the Minister of Finance, that was before 2014, they used just to give us a ceiling, indicative ceiling. You know what will happen? People will start developing activity according to the money available, which was quite very wrong at that time. We got some before that reform. We had some experts from one of the country, high income country. They come to train government officials about how reforming the planning. So we started the planning. Now we spend 3 months in planning the overall government. Planning without an indicative budget. When budgets come, we prioritize. So I think we have to start with it's and one of the trend I remember when I was telling you know why the indicative budget ceiling budget, it doesn't fit your priority, your wish list. That's what your wish list, because that's a human being reaction. When you see money, you want to even those where you have made promises to the people, especially the politicians, or you found that all the development budget, I remember that time, all development budgets, or the overall ceiling or the budget, development budget took around 60%, but now it took 40%, and we are surviving very well. But because politicians want to put in a health center, a hospital, even if people are even if in express, because you have timeline, put everything. Because of sometimes even planning is not going well. That's what I want to share. Thank you very much. Let's start by the planning and then budgeting after. Thanks.
I think that's a great ending point. So unless someone's really dying to speak, and then 2 minutes, and then Wangari will speak.
Thank you. So just on that, the starting point that we found in Pakistan for multi-sector nutrition budgeting was target, having a single common target for all sectors, for all departments. And under that single target, for example, like you have a climate change target to meet. So under that single big target, having specific targets which are specific to each department or sector, which then get part of they become ingrained as part of their internal plan and then internal budgets. So going backwards, the target, big target, specific targets, then the planning, and the last part then was the budgeting. Thank you.
Thank you. This has been very useful. And now, what did I just miss? One more.
Encore, je vais vous demander de porter vos casques comme c'est en français, je vais vous faire souffrir un peu. Mais excusez-moi, mais pour cette thématique, l'expérience que je peux donner du Burkina, c'est que en novembre 2020, je pense, on était au Rwanda pour apprendre de l'expérience de Imigo. Je pense que je prononce bien le mot. Et l'idée, c'était de pouvoir mettre en place le programme de santé communautaire à partir des municipalités, des communes. Et nous avons commencé le processus de construction. D'abord, quels sont les éléments qu'on met sous le leadership de la commune avec 5 départements ministériels, santé, éducation, eau, assainissement, agriculture, et puis j'ai oublié le 5e. On a fait le processus pendant 3 mois de construction des éléments jusqu'à obtenir le budget pour qu'on puisse dire nous voulons que chaque famille devienne une famille modèle. La commune a sa part de responsabilité Et chaque famille a sa part de responsabilité et nous avons défini 117 indicateurs, 54 indicateurs pour chaque famille et le reste pour la commune. On a fait l'immersion dans 15 communes pilotes, former tous les acteurs sur financement, bien sûr avec l'appui des partenaires. Et au moment où on devrait faire le lancement officiel qui devrait être signé par le président du FASO, bon, il y a eu coup d'État et puis bon, c'est suspendu pour le moment. J'ose espérer qu'on va reprendre ça dans peu de temps. L'idée, c'est que la santé communautaire, c'est vraiment ce qui va nous permettre d'atteindre la couverture sanitaire universelle. Et si on investit massivement à l'intérieur, dans les municipalités, on est sûr que beaucoup de maladies ne vont plus parvenir dans les hôpitaux. Merci beaucoup.
I was kind of influenced to say something by the idea of target-based budgeting, because I think I'm Juliana Ball from Columbia University. One thing I'm really interested in is accountability, but not from the perspective of, did you do what you said you were going to do, but from the perspective of, did we give you enough money to do what you were supposed to do? And a lot of times we set targets without understanding, are we allocating enough funds to actually achieve those targets, whether they're outputs or outcomes? So that outcome-based costing should also be part of a budgeting process. And I think we tend to forget about that. We sort of come back and say, did you achieve your target? Did you achieve your goals? But the question should be, did we actually provide enough financing and funding to do that, for that to happen? So that was something I wanted to mention.
Thank you. I'm tempted to give the final word to the government, but I think listening to some of the conversations, and that was why I was so interested in the intervention from our colleague from Burkina Faso, is that in many ways what we found in the literature, where the easiest and most reliable thing to do is to start with a very centralized model, because that has a best chance of working. And then the question, I think, listening to a lot of you, is whether that model is implemented in a way that builds capacity and trust and the ability to actually work together without using the scarce energy and time and resources of the very center of the government. So using these opportunities, even if it's initially a centralized policy, to start to think of ways to build the relationships and the systems that allow decentralized cooperation might be one of the themes that we're getting out of this. And with that, I'd like to thank you for sharing all of your wisdom and experience.
We'll move seamlessly from the academics to government. And Wangari, you have now all these interesting questions to tackle. And I know I have full confidence that you will tell us exactly how it all goes down in the halls of State House.
Wow. First of all, I think there's like some sabotage. Joe always puts me like after lunch when people are jet lagged, day one. So I don't know, maybe it means there's nothing much for us to say. Fewer people in the room means less accountability. But I like this new definition of accountability. So the question should be, did you give us enough resources to do the task that we were asked to do? My name is Wangari Nganga. I work in the President's office in Kenya. I would call myself a health systems person, but in the 4 years I've been there, I have been asked to do a lot more than health, which is actually going to be a few of the things I say. So I don't know how much I should tell you about Kenya, but we are a recently decentralized way of running government. Recently is only 10 years. Prior to that, we were a centralized government. We devolved some functions, some remained central. The key difference is usually health was devolved, education wasn't, unlike our neighbors in Tanzania, where both are decentralized. We decentralized some parts of education, so early childhood development is decentralized, primary, secondary, high-level education is not. Most parts of agriculture is decentralized, national security isn't, so it's kind of, there's some method to what is decentralized and what isn't. Decentralization has majorly included decentralization of resources, but not fully. So for example, programmatic funds within the health sector are not decentralized as the rest of the system funds are. So that's Kenya, but for the last 10 years, there has been a very big push on health reforms, different elements of the health system, human resources for health, health financing, service delivery, building more hospitals, fulfilling political commitments, wishes, everything we have done in 10 years. But in the last 4 years, the big push has been on health financing. We boast a lot about our National Health Insurance Fund. Yes, it started as a National Hospital Insurance Fund. Yes, it was for civil servants initially. It expanded to include all formal sector workers. It expanded to include anybody who can afford. That word afford has a very different definition depending on who you ask, but everybody is welcome as long as you have $60 a year for you and your family. It does also include access to private hospitals. It has undergone a very recent reform. It is now National Health Insurance Fund, and hopefully with the title function will also follow fairly soon. The thing we are most proud about is it is about 56 years old. It is the oldest on the continent. We are very proud of it. Don't tell us about fragmentation and inequity and all those other things. It is 56 years old. It is still standing. It has not been dissolved. We are progressively moving towards all the other system goals. I think one of the biggest achievements we are proud of as health system people coming into the new administration, we have a very, very new government sworn in on the 13th of September 2022, is health remains top priority. Having said all that, I am about to tell you that the system will perform how the system will perform. It is unlikely that the health system will do so well if the education system isn't. It is unlikely that the Health Insurance Agency will do a very good job of collecting revenue if the National Revenue Collecting Agency isn't doing a very good job. It is also unlikely that you shall get the president to have a conversation only about health if people are also hungry and not educated and don't have jobs and. And just as we were speaking around the room, I think perhaps the two institutions that are still very centralized in their expectations is the institution, their executive offices of the president, of the governor, of whatever the corresponding title, and the community. The community here, I'm going to be selfish and pick the mom, the mother, has to figure out how all the children eat, how they go to school, where they sleep, where they have to figure out that. And that is what they were promised by their president-elect, governor-elect, senator-elect. And then all us systems people, Ministry of Finance, Ministry of Education, Ministry, fragment all those promises and try to coalesce them at the bottom. And admittedly, we don't do a very good job of coalescing at the bottom. We do a very good job of fragmenting at the top. In the name of targets and objectives and all that. There's another point I wanted to bring about that I like to call false dichotomies. We must appreciate that there's a time and space for what there is. I was still in school at the height of HIV pandemic in Kenya. If I was who I am now, I would probably still have started a HIV program. I think that was the correct thing to do at the time. It was. Our life expectancy was 49. 49 years. I am sure the average age in this room is higher than 49. 49 years. Our life expectancy now is 67. In 20 years, we have moved 20 years. I am hopeful we shall move 20 years in another 20 years. It was the right thing to do at that time. Maybe the question becomes, and this was a challenge Joe gave us this morning, who is that who is doing the overall systems thinking? Not applying the myriad of tools, but just thinking that at this time, this is the moment in which we need an HIV program, a TB program, an immunization program, a COVID program, whatever other program you want to start, because this is an emergency for the country at this moment. And at point X in time, it is time to morph into the next thing. For Kenya and a lot of our neighbors, there is a very big push at those executive level offices to have a lot more integration, not just across sectors, but across levels of government. And I'm extremely excited that HSR this time is in South America. I am going to write a letter of request to remain on a learning agenda, because I think there's a lot to learn from what our colleagues here have done on cross-sectoral thinking and delivery. I like the presentation from Octavio this morning. He said Seguro Popular was for the population who did not have social security. I don't know how many noticed that he used the term social security. This is not a word we use health insurance. Yeah, correct? But this is exactly right. That same person you're trying to get health insurance, you need to get them some sort of subsidy for economic sustenance, you need to get them some sort of subsidy for education support, you need to get them some sort of subsidy for food. It is the same beneficiary. The same beneficiary. But for some reason, we believe that, you know, if I come with my conversation only about health insurance, you need to stop doing everything else you're doing and listen to mine. It is an unrealistic expectation of the executive office. It is an unrealistic expectation of the mom, of the mother. I think I've said enough unpopular things. I stop. What didn't I say? Yes, I said everything I wanted to say. No, I didn't say people matter. Did I say people matter? I needed to say people matter. I needed to say people, and I'm quite serious about this. Systems matter. I'm about to tell you people matter more than the systems, however heartbreaking that might be, however much we're trying to create systems, people matter more than the systems. You need the people to create the systems. You need the people to trust the systems you've created. You don't trust systems, you trust people. So we must develop people as we develop the systems. I've said everything now.
All right. You don't sit. I think you should just stay up there. There are questions already.
Thank you very much for these reflections. I want to ask you something. You said that it's difficult for the president of Kenya to speak only about health when there's children starving or communities without education. Has this view changed with the pandemic? The pandemic made it very clear that without health, there's no economic prosperity, there's no security.
Wangari, if it's okay, let's just collect a couple of questions. Any other questions?
Thank you so much. I'm Ali from Uganda. We've heard that NHIF or NHIS Kenya has been anchored in the highest office. It has been used as a tool to reduce fragmentation and also targeting those that need subsidies, which is the best thing we can do. So you need to tell us about that and how it's going. Two, of course, we also understand that, yes, I think what you want to tell us that as you sell health, you need to work with other institutions. I mentioned in the morning that we are now looking at health insurance as a social protection. Sometimes they call it social security. And therefore, when we are going, we are talking about social security. And we're a team of about 5. sectors, pension scheme for public sector, NSSF for private sector, and then insurance for health. So that we're able to say. So I can agree with you, but of course the other answer, the question stands. Thank you.
Another question, we're collecting them in an integrated way.
All right. That's Wangari. Good to hear from you. So for someone who is an embedded person within the policy environment, so how have you been able to influence the president's thinking about health? So for instance, in Nigeria, we were just discussing last week at an event where policy dialogue, like how do you make politicians see health, I'm using the word sexy, excuse me, to be a sexy thing for them, because most times they will tell you that health does not win elections for most politicians. So, and the things we ask for in health, they seem not very tangible. So if you say you want to reduce maternal mortality, for a politician, how will he win election with pushing for that? So I'm wondering, how do you help to frame health in such a way that it's acceptable, or you make sort of motivate a politician to really invest in health? Yeah, thank you. Because they will prefer build hospitals, build roads, and all that. People will connect with success as politicians.
Good. Are there any others? Yes, no?
Was there a question?
Yes, one more.
I was thinking about your experience with HIV and then also your appreciation for the socialized approach that is taken by the Latin American continent. And I was thinking about how a lot of times we don't talk about how the global agenda really prioritizes or shapes local priorities. We see that with HIV, we see that with malaria, we see that with some of these very big financing initiatives, donor financing initiatives that affect priority setting at the local level. So my question is, my question is, since you're going to be here on a learning agenda, how do we start to begin to think about how, since we're talking about decentralization, the local priorities, whether it's continental or regional, begin to affect and shape and influence the global agenda setting system of focus? Thanks.
Okay, over to you. Yeah. Okay, all very simple questions. I have one-word answers for them. I still have the permission to say unpopular answers, correct? I don't know that COVID changed how. Okay. COVID proved to the world that without health, the world stops. But the reason a lot of countries our side stopped was the economic halt. It was actually not the disaster, the health disaster. I'm waiting for people to stop cringing. It is a fact of the matter. When action really became multi-sectoral was when there was no longer revenues flowing into the country, out of the country, within the country. Everything stopped. When by the time Kenya was shutting down, I think it was the height of a pandemic in Italy and Spain. And I think we were shutting down, waiting for Armageddon. We didn't know what will happen. There were no prospects of a vaccine. We didn't know. But 3-4 months after that, I think was the first subsidy from Treasury through the Ministry of Labor and Social Protection for food, because people couldn't go and work, a lot of the informal sector. 6 months after that, the crisis was an economic one. It was not a health one. So has the system level thinking improved because of COVID? Yes, but I'm not sure that the resultant effect is that health will stop. What was proven is that the economy will stop the economy. However, there was a lot of infrastructural investments in health. And I'm going to tie this to what Francis asked. I don't know that it is an either or for us yet. I did my master's in London, where people going to the hospital more was a bad thing. Is it still? I don't know if it's still a bad thing because it kind of meant overutilization. This is a concept we don't understand. We need people to come more, right? So I don't know that it is entirely a bad thing. Probably it is not necessarily a good thing when the facilities are just next to each other and somewhere else doesn't have. But I don't know that we are really there yet where we don't need more infrastructure, where we don't need more roads, where we don't need more this or that. And this is what I was describing as false dichotomies. I do think there is a space for both and. So I don't know that I have influenced the presidency. Probably I left more influenced. And I'm here trying to preach this gospel fairly unsuccessfully to this room, that perhaps we need to be a little bit more political thinking. There is a space to merge our health system priorities and the political objectives, which are actually not very far from each other. What the elected person wants is to be elected again, and the way they'll be elected again is by doing what the electorate wants. I think everyone here in the middle, from the ministry level, the decentralized government, the parallel agencies, the civil society, all of us here are the ones who are confused about this message. But the elected person and the elector are clear. Doesn't mean that there's no power imbalance and one doesn't take advantage of the other. It happens. I'm not oblivious of that. But in our efforts to conglomerate, I think we are fragmenting more. So this is what I would say about winning elections. I think it is the big challenge is still really lies with us, health systems people, or systems people in general. I can see I have support to maintain my learning agenda here, after which I hope I can be given some sort of certification and I can be a social sector economist, not a health economist. And once I am a social sector economist, then maybe when I say we need to combine rather than fragmentize, someone will listen. The immediate past President Uhuru had a very big youth agenda, which was implied. He didn't declare it as one of his big four, but before the end of his presidency, it was squarely conferred upon him, even by the world. He was a global champion for Generation Unlimited. What is the youth agenda? Is it a Ministry of Youth agenda? Is it a Ministry of ICT agenda? Is it a Ministry of Labor agenda? Is it a Ministry of Health agenda? Is it a Ministry of Agriculture? Whose agenda is it? Whose agenda is it? And till now, we struggle to have that harmonization even of conceptualization at the ministry level, because everybody has their own kind of space. So what we keep doing is we keep moving the youth around. So it's youth and ICT, I think, this time, or the youth are with the women, or the youth are with the health, or the youth are in labor, or the youth are wherever they are. Climate change is another one that we are starting to shuffle around. It is everyone's business, yet it is no one's business. Adolescents are another group we've actually completely ignored because we don't understand them. There was someone who made a comment this morning about majority, I think it might still have been Octavio or Martin, majority of the people being uninsured being children. And I'd never thought of that, because Kenya's population is 50% under 18. I wonder what the statistics is for how many of our children are uninsured. It's probably 90%. You know, who knows? Who knows, because of how we phrase issues. But the executive office, and I'll speak about the presidency because this is where I've spent time, but it is the same of the governor's offices. I cannot think of one thing in isolation. I can think of the youth. Is that one thing in isolation? But our experience of the youth is in sectors. So this is the only comparison to this person is the mother, because the mother cannot think of Ministry of Agriculture in the house, and then Ministry of Health, and then Ministry of Finance, and then Ministry of Education in the house. She just needs to figure everything out with her $2 a day. So there has to be this kind of interrelation. There was the last question on how do we kind of elevate local priorities to shape the global agenda, vis-a-vis vice versa. I still think it is this integration agenda that's going to rise up. But I'm also going to again reiterate on the false dichotomies. Everything seems to kind of be either or. You either do programs or you do a system. You either do primary health care or you do high level care. You either do health insurance or you do tax fund. You either do. You don't have to either or. But how come there's no one from South Africa? They always tell us you must do something. You must not do one or the other, right? You can do both and you actually have to do both and, because systems, as we've been talking about the entire day today, are progressive and they are made by human beings. So the human beings who make the systems matter, and there has to be someone who is on the business of thinking. So that this is the most appropriate at this time to get us to point B, and when we're at point B, then we think again that what needs to get us to point C. Did I say?
Thank you, Wangari, for taking these tough questions. And I agree with you. I feel like it isn't either or. I feel like, we started this discussion about fragmentation, and clearly, just the word, we all hear it and it's negative. We don't want fragmentation. And the end is clearly to integrate, but the means are quite complicated, is what we heard repeatedly in all three segments of this discussion. And I think what I really appreciated from your comments was that these aren't three different problems, but there are a lot of linkages. And I think, Susan, you brought this up too. Why is cross-programmatic integration hard? It's also got to do with the devolved nature of government. And so these are not different questions, but actually related questions. So thank you all. Let's give a big round of applause to all the speakers and all of you for participating with your ideas and your questions. And I hand it back to Joe.